different cutoffs have been proposed for AMH as a marker of polycystic morphology, hyperandrogenism, or oligoallomutation. But only it has been found to be a good alternative to PCO morphology, that is imaging evidence, not for hyperandrogenism and oligoallomuria, just because of lack of robust data. The cutoffs are different, but as an alternative to PCO morphology, 4.1 nanograms per ml is the cutoff that we are accepting for AMH. So in the 2018 guidelines, AMH did not really have a place. The 2023 guidelines clearly states AMH could be used for defining PCO morphology, not PCOS, but PCO morphology only in adults, but it should not be used as a single test. So for the elder sister with not so clear-cut picture of PCO morphology and ultrasound, AMH was done, which was actually higher than the cutoff of 4.1. For the non-obese younger sister who was clearly having polycystic ovarian morphology on imaging, AMH was not indicated. Talking about metabolic parameters, till 2018, PCOS along with additional risk factors like smoking, obesity, dyslipidemia, only they were considered to be having a high CV risk, and only overweight and obese PCOS was indicated to do a fasting lipid profile and other CV risk tests. But as we all know, even non-obese PCOS have equivalent cardiovascular risk possibly, and therefore all PCOS patients should be considered to be having high CV risk and be screened for additional CV risk factors. And PCOS in isolation, PCOS alone, should be included in CV risk prediction tools. Talking about diabetes screening, in the last guidelines it was only for the high-risk PCOS, and either fasting or OGTT or HbA1c could be used, but OGTT only for the high-risk cases. But again, as per the last guidelines, all PCOS cases should undergo testing for dysglycemia and preferably with an oral glucose tolerance test rather than fasting or HbA1c. And there is no role of measuring insulin either for the diagnosis or for the monitoring of treatment of women with PCOS. Even if we get a clear picture of insulin resistance or we do not have any picture, insulin assays are not indicated in the diagnosis or management of PCOS. Of course, we should also look for the other risk factors like the risk of obstructive sleep apnea, metabolic dysfunction associated with steatotic liver disease, osteoporosis, and endometrial cancer risk. We all know, but we need to counsel our patients regarding these risks as well. So coming back to our two sisters, both the obese and non-obese sisters, both of them have to undergo anthropometry, metabolic risk screening along with psychosexual assessment. Coming to the management part, as you all know, lifestyle modification still constitutes the pillar of management of PCOS. It is the first-line therapy for obese as well as non-obese PCOS. And talking about changes, only thing that has changed regarding the exercise duration for maintenance of body weight and good health. So it was only 150 minutes moderate intensity last time, and it has increased to 300 minutes. So of course, the more you exercise, the more you do aerobic exercises, the better it is. And talking about treatment, pharmacotherapy, combined oral contraceptive pills remains the first line both for hirsutism as well as for oligoamenorrhea. No specific recommendation regarding any particular formulation or any particular dose, but yes, we should use the lowest effective estrogen dose, preferably those containing 20 micrograms of ethinyl equivalent. Many of us still use progesterone only OCPs, and it was not there in the last guidelines, but thankfully our teachers have taught us that it can be used. Possibly it was there in some guidelines 30 years back, and it has again come in the recent guidelines. So progesterone only oral contraceptives can be considered in patients where only endometrial protection is desired. So somebody having only oligomenorrhea, no clinical or biochemical hyperandrogenism, no metabolic risk factors, there may be a case for given only progesterone only OCPs. Metformin oral therapy, of course, we can give it in adults with PCOS or obese or having IgD, but as per recent guidelines, it also can be given in adolescents at risk and non-obese adults. The maximal dose being 2.5 gram in adults and 2 grams in adolescents. Combination of COCPs and metformin is not superior to COCPs plus lifestyle modification and comes with additional GI side effects of metformin. Can be considered in those who are really very obese and having impaired glucose tolerance or other multiple risk factors for diabetes. When we are using a combination of COCPs plus anti-androgens for hirsutism reduction, we are going to add the anti-androgen only if there is no reduction in hirsutism of with COCPs after 6 months of therapy. And it's important to explain the side effects. Spiral induction, all of us know underutilization of male figures, that's why we do not use it alone without COCPs. But for cyclotron, there is small but genuine risk for meningioma, and of course, finasteride and symptomide high risk of